Hello, today I'll tell about Fogsi guidelines on updates of endometriosis management. So, first thing is how to diagnose endometriosis. So, in menstruation, there are symptoms like pain, discomfort, always, and there is out range of symptoms. Sometimes it is associated with GIT, okay, other systems. So, first thing for diagnosing of endometriosis, we need to ask the history, then we need to do the clinical examination. So in history, we'll ask what kind of pain she's getting, whether it is cyclical or non-cyclical signs and symptoms. Not only pain, there is deep dyspareunia, dysuria, dyschezia, and pelvic pain. And some females will come to infertility clinic and with endometriosis that they are not able to conceive. Okay, and some with abnormal uterine bleeding they'll come. Some will come with painful rectal bleeding, shoulder tip pain. Some will have a shoulder tip pain, hemoptysis, chest pain, cyclical scar swelling. Some will have chronic fatigue also, chronic pain and fatigue. So this is the history. Basically, pain is the history. So how to explain the pain? Dysmenorrhea, then you have scar swelling, pain, difficulty in conception, and abnormal uterine bleeding. Okay, so we should ask about the pain symptoms in history. So on endometriosis diagnosis, history is very important. Coming to clinical examination. So clinical examination, we have, uh, we should have a per vaginal examination first thing. So PV should be done for adolescents and young females who doesn't have a previous intercourse history. Then rectal examination is done. PR is done. Okay, and clinician should should rule out the non-endometrial cause of pain also. Okay, non-endometriotic cause of pain can also occur by history, physical examination, imaging studies. Okay, so deep endometriosis where you have a nodules on the vaginal wall that you can see clinically. Visible nodules are also seen. Okay, and these visible nodules are seen when the female is menstruating. Then further diagnostic steps of evaluation should be done. Uh, After clinical examination, we'll send her for investigation. So first investigation you'll do is ultrasound. What? Ultrasound. Ultrasound is done, and that too transvaginal ultrasound is best. Okay, it used to diagnose, or it can also helpful in excluding the ovarian endometrioma. Okay, that's about ultrasound. In ultrasound, we have rectal endometriosis can be detected by probe tenderness. If you keep probe in the posterior fornix, you have a tenderness that is probe tenderness. Okay, sensitivity is increased by 3D ultrasound, and linear ultrasound is also recommended if you want to rule out any deep lesions. MRI is generally not done, but if MRI is done, it adds on to the ultrasound. It detects lesions more than 5 mm. Okay, endometrioma or dermoid, we can differentiate by means of MRI. Okay, so generally it adds on the ultrasonic findings. That's important. More than 5 mm, we can find out the endometrioma. Coming to empirical treatment depends upon the diagnosis and laparoscopies. If the images are inconclusive but the patient is having pain, then inconclusive image you can go for laparoscopy and biopsy should be taken. If on biopsy, if there is no endometriosis, then also we can't rule out endometriosis. That's one important thing. And empirical treatment is given, like hormonal pills or laparoscopy can be given. Um, which is superior to like hormonal pills or laparoscopy or progestogens? Nothing is superior to any other drug. Okay, there are pros and there are cons of each and every approach. Type of lesions. This is important. What are the types of lesions you'll see? You'll see powder burn lesions or black lesions. We can see white opacified peritoneum, glandular excrescence, flame like red lesions, peritoneal pockets or windows, clear vesicles, yellow brown patches, unexplained adherence of the ovary. Ovary will be adhered to the peritoneum, and there is thick chocolate colored fluid or thari fluid, additions of the posterior lip of broad ligament or other pelvic structures. Okay, so basically endometriosis means you should suspect additions, and we can see the ovary also being adhered to the uh, below peritoneum, and we can see the lesions like powder burn lesions, red flamey lesions, white opacified lesions. Okay, Coming to biomarkers, there are no special biomarkers. CA125 is non-specific one. Salivary microRNA is being tried. Next topic is adolescent endometriosis. So adolescent endometriosis is something like if the female is about 13 to 19 years of age and she's having endometriosis, then adolescent endometriosis. It considered about 3 to 5%. Okay. Severe dysmenorrhea through absenteeism is seen. Severe dysmenorrhea involving the daily activities, chronic pelvic pain, and all the pains will get. So these are not responding to NSAIDs or OCPs. Uh, kind of pain will be present. And carefully, if we take history, there are risk factors such as family history positivity of endometriosis, genital malformation, short menstrual cycle. So why age of menarche important in menstrual history? Because endometriosis is seen in case of early menarche. Okay, short menstrual cycles. Okay, then help to suspect endometriosis in adolescents with cyclical and non-cyclical pain. History important, physical examination is important. We should do take the age, cultural background, risk factors as well. Transvaginal ultrasound is a investigation of choice, but in adolescents, as it is inappropriate, so we can do a transabdominal, transrectal, or transperineal ultrasound. MRI in selected cases. Okay, so 3 to 5% is the incidence. School absenteeism, severe dysmenorrhea is seen. If she is not being treated by NSS or OCPs, then you can go for laparoscopy. Okay, then. Even in adolescents also you can give continuous flow that is safe. Okay, we can give for pain. It's a first line of management. Progestins can be used. New progestins is dinogens which relieve the pain. Mild reduction in lumbar bone density with improved partial after discontinuation. Okay, then levonorgestrel LNG IUS can be used in case of sexually active adolescents. Adolescents and the family members should be informed that if you do surgery, battle over endometrioma, then if there is bilateral endometrioma, then go for unilateral ovarian surgery. Contralateral ovarian conservation is better. Okay. Nowadays, for adolescents, GnRH antagonists use is being studied. Okay. So that's about adults in endometriosis. In next, I'll tell about the endometriosis and infertility. Thank you.